He has published 2 peer-reviewed papers on the use of ozone in clinical medicine. He is the founder of the Nevada Center of Alternative and Anti-Aging Medicine, which is devoted to the prevention and treatment of aging and age-related diseases by improving mitochondrial efficiency. He's developed and pioneered the first method to measure mitochondrial efficiency in a clinical setting. Please give a warm welcome to Dr. Shallenberger.
Good afternoon, everybody. I want to thank the organizers of this event for inviting me. It's really a privilege and an honor to be able to speak to you guys. Just went to the luncheon awards presentation. It was just marvelous. So it's just great being here with you people. I do not have any financial interest of any product in my talk or with any companies offering grant monies for this continuing dental and medical education program. But I do have an interest in preventing disease, as I know all you guys do. And I've always said the best treatment for any disease is don't get it. And I really believe that. So I'm so happy to be here with all you that believe basically the same thing. We're going to talk today about one would say is one of the arguably the most difficult disease to clearly prevent. It's hard to just tell somebody, I more or less guarantee you won't get cancer. It's also one of the more difficult diseases to treat, as you already know. So we're going to see if we can't get down to some very core issues that you may or may not have considered with respect to cancer. As I see it every day, you do one of two things. You either build health or you produce disease in yourself. That's from Adele Davis. She died of cancer at the age of 65. I'm glad that Dr. Haley put up us some mitochondria before, so now everybody is really up on their mitochondria, and they're all happy about it, and they know about all these little things in there and all the stuff that goes on in mitochondria. But today what I'm going to submit to you is that this particular little blob of biochemical activity, every one of your cells has thousands of these, and this is where all the action is. You want to know the ultimate key to preventing disease, including cancer, you're going to think mitochondria. That's why the talk this morning on mercury was so absolutely essential to even what I'm going to be talking about, because mercury screws this up. And you're going to see in a second here what that cascade of events involves. So we go back to Otto Warburg, who was born in 1883. He was a German physiologist and medical doctor. He won the 1931 Nobel Prize for Physiology and Medicine because of his paper describing the metabolism of tumors, a metabolism nobody else had described before. He almost won the same prize again in the 1940s, except World War II kind of cut him out of that. Warburg proved that the fundamental difference between normal and cancerous cells was that normal cells had effective mitochondrial function, whereas cancer cells have deficient function. Now that right there ought to tell you a lot about how to prevent cancer. Write that one little sentence. And what's interesting about cancers, we'll see in a little bit, is that they have deficient mitochondrial function, but it's not because their mitochondria are deficient. It's because they decide to turn them off. They decide to not use mitochondria. Therefore, it would be possible if you turn those mitochondria back on to prevent cancer and even to enhance your treatment of cancer. He also wrote The Prime Cause of Prevention of Cancer, which he presented in a lecture at the meeting of the Nobel laureates on June 30th, 1966. In this speech, Warburg presented evidence proving that the primary cause of cancer is decreased mitochondrial function. And shortly after that speech, I suspect that the whole idea of mitochondrial function in cancer and disease was completely forgotten because we don't hear anything more about it. Until about 4 or 5 years ago, when all of a sudden there began to be a lot of interest in Warburg, and I think probably because with new technology now, new abilities to measure mitochondrial function, it turns out that Warburg's principles were now being proven. So here's a paper in question for this, a 2005 paper called Mitochondria and Cancer, Warburg Address. says cancer cells have decreased mitochondrial function. That's what Warburg said. This decrease in mitochondrial function occurs first when the cell is healthy. The decrease in mitochondrial function causes increased free radicals to form. So as your mitochondria, as you'll see, produce free radicals. They, by the way, are essential to our health. They're not bad guys. But when mitochondrial function declines, we produce an excessive amount of them. What do these excessive free radicals do? Well, they mutate the nuclear pro-oncogenes. That's called initiation. That means the cell is now being initiated into turning into a cancer cell. And they drive nuclear replication. In other words, it grows faster and faster. We'll see why. And that, what do we call that? We call that a mutated cell that's growing very fast. That's called cancer. This paper is induction of oxidative metabolism. That would be improving mitochondrial function. So induction of improving mitochondrial function by mitochondrial frataxin. Frataxin is a chemical which will improve mitochondrial function. Okay? Inhibits cancer growth. Otto Warburg revisited. This is another 2005 study. And the authors note that cancer cells exhibit multiple alterations in mitochondrial content, mitochondria in the cells, their structure, and especially their function and activity. And what they did is they caused those mitochondria to overexpress the protein frataxin in several colon cancer cell lines. What would that do? These are cancer cells, and they're improving their mitochondrial function through this genetic alteration. So what happened to those cancer cells when their mitochondrial function was improved? Consistent with Warburg's hypothesis, these cells had decreased growth rates and increased doubling times, inhibited colony formation capacity. So the first one says they didn't grow as rapidly. Now remember that, because we'll come back to that. Second one says that they couldn't spread as rapidly. We'll come back and talk about that a little bit. And the third one says reduced capacity for tumor formation when injected in mice. So they don't metastasize well. And we'll look at all these things in a little bit in the context of mitochondrial function. And the author says these results support the view that an increase in oxidative metabolism, an increase in mitochondrial function, may inhibit cancer growth in mammals. And that's what we want to do. There's a 2004 paper called An Alteration of the Bioenergetic Phenotype of Mitochondria is a hallmark of breast, gastric, lung, and esophageal CA. It's a review paper. They found, they looked at quite a few cancer cells, they find that mitochondrial function is depressed in all cancers studied so far. And the authors say the findings reported in the present paper, in addition to previous findings in liver, kidney, colon carcinoma, strongly suggest that altered bioenergetic function of mitochondria is a hallmark of carcinogenesis. That means what started the cancer in the first place, as was hypothesized by Warburg almost 80 years ago. So here's kind of the basic thing that I want you to get. This is worth writing down. A cell becomes cancerous when it is advantageous for that cell to downregulate its mitochondrial function. Now, why would it be advantageous to downregulate mitochondrial function? Downregulating mitochondrial function allows it to adapt to decreased oxygen availability. So when you have an area in the body that had decreased oxygen availability, the cells in that area have to adapt to that. By downregulating the mitochondria, they can. That's one thing. It allows them to divide more rapidly. In other words, control their growth rates. So if you downregulate your mitochondria, you can grow more rapidly. If you downregulate your mitochondria, you can metastasize and spread with greater ease. If you downregulate your mitochondria, you can get a competitive edge on all the surrounding cells, keeping in mind that the environment is hypoxic. It's deprived of oxygen. So in that environment, it's good to downregulate your mitochondria. And the cells that can do that best, the cells that are ready to do that, they're going to turn into cancer. And finally, to avoid apoptosis. Apoptosis is induced by mitochondrial function. You shut down mitochondrial function, you shut down apoptosis. And isn't that the nature of cancer cells? This is the stuff they do. They divide more rapidly, they spread, and they don't die. So it's an adaptation. This is what any cell that has the capacity to do this would do in the presence of inadequate amount of oxygen. So there's a little bit more to that story. So we're going to go into that and kind of dissect that a little bit and throw some pieces on the table, and hopefully by the time I'm done here, those pieces will make some kind of sense, make a real picture. So mitochondrial efficiency means decreased oxygen utilization. What that means is that oxygen is getting into the mitochondria, but it can't be used properly. You know, we talk all the time about you can eat good food, but if you don't digest it and utilize it, what's the point? This is so true of oxygen. Just because we take in oxygen, just because our O2 sats are 95, doesn't mean we're using it very well. So mitochondrial function means decreased oxygen utilization. So let's look at what that amounts to. This is basically the scenario. That would be your cell. Here's your mitochondria. So you got three big players. You got some oxygen. You got to get the oxygen in there. You got to have all these things to do that. You got some fat. You got to get the fat in there. You got glucose. Got to get glucose in there. Then now these things just going in there. They don't automatically just go in there. There's a lot of activities that have to take place to get all three of those guys in there. But assuming you get everything in there, which might be a big assumption in a lot of people, then the fourth issue is the mitochondria itself. And it's under the influence of things like mercury, lead, cadmium, arsenic, you know the list, hydrogenated oils, all kinds of toxins. It's also in the marked influence of thyroid and various hormones and such. So this is your fourth thing. So if you get those three players into the mitochondria, and if the mitochondria are optimally functioning, bingo, you get this. You get a lot of energy and a limited amount of free radicals. You need free radicals. Keep in mind, they're essential to your health. You just don't want to have too many. Now that's what oxygen utilization looks like when it's running really perfectly. Okay? We'll come back to that. Look at that in a second. So to reiterate, oxygen utilization, also in the literature, you will see the term aerobic capacity used. It means the same thing. The process is the process whereby oxygen metabolizes either fat or glucose into water. The high energy molecule called oxygen, lowest energy molecule on the earth called water. As that goes from that, energy gets released. That energy is released in the form of heat, NAD, nicotinamide adenine dinucleotide intermediate. As you will see, oxygen in cells actually doesn't do anything, except it forms this stuff called NAD. We'll talk about this in a second because it's critical. And then NAD is what causes stuff to happen. Now, there are actually some other oxygen intermediates I'll mention in a second, but NAD is the one I want you to focus on because that's the critical one that we look at, and it's in science all the time. So it's converted to water, heat, NAD, free radicals, and then this stuff called ATP, which is what drives the energetic components of all the reactions in the cells. So oxygen, like I said, it doesn't do anything directly itself. It works through the intermediates, NAD and ATP. And to a lesser degree, these are some of the other intermediates. This is niacin-derived. One of the reasons why niacin is so handy. This is riboflavin-derived. Another reason the riboflavin is critical. These oxygen intermediates are the bottom line for every cellular function there is. This is kind of a diagram that you don't have to get yourself too crazy over, but we're just going to point out a couple of things. This is the mitochondria, this little blue line. And here's fat. Fat's getting into the mitochondria. Here's glucose getting into the mitochondria. In here you got your Krebs cycle, you got your electron transport chain. And basically what's happening, notice this, the electron transport chain is producing NAD. The NAD then diffuses out of the cell, out of the mitochondria, and notice that every one of these reactions is NAD induced. So NAD goes to NADH, NAD to NADH, NAD to NADH. That's a reversible reaction, so the ratio becomes critical. If the ratio is in favor of NADH, the reaction goes that way. Okay, so what happens if the ratio starts becoming in the favor of NADH? The entire system shuts down right now, and I don't care how much oxygen is in there. This is what we talk about when we mean oxygen utilization. So knowing that, what do you suppose the NAD to NADH ratio would be? We'll talk about it in a step. Mitochondrial deficiency and decreased oxygen utilization are the metabolic equivalent of holding your breath. I mean, if oxygen only does one thing in the human body, isn't that interesting? I mean, every vitamin, mineral, hormone, things that you talked about has a multiplicity of things that it does. Essentially, in the human body, oxygen only does one thing. It goes in the mitochondria and does what I just showed you. I find that's pretty fascinating. So, if that oxygen can't do the one thing it's supposed to do, isn't that pretty much the same as not breathing? Yeah, so we basically use this term functional hypoxia. It's the metabolic equivalent of functionally be the same thing as if you just went around all day long chain smoking cigarettes or holding your breath. And this term functional hypoxia was developed by Levine and Kidd in their classic text, Antioxidant Adaptation, in which they said decreased oxygen utilization creates this functional hypoxia, which accelerates free radical formation, while at the same time it exhausts all the antioxidant buffering systems, creating a very excessive activity of free radicals, which, as we've seen with the previous slides, initiates and promotes carcinogenesis. So functional hypoxia is where this stuff doesn't happen. Here's the oxygen. According to my medical school, everything's cool if your O2 stat's all right. You don't have COPD, and you're not in heart failure, and you have halfway decent circulation, your O2 stat's okay, that's fine. They more or less forgot about the fact, oh yeah, there's this thing called lipolysis. You got to break down the fat, you got to exchange it in the liver, you got to transport it, you got to go through beta oxidation, blah, blah, blah. They kind of forgot about the whole thing about glucose. You have to interact with the glucose, you have to have glycogen, you have to have insulin, it has to get into the cells, so forth and so on. They kind of forgot about maybe these things aren't quite working, maybe there's toxins involved, but anyhow, so functional hypoxia is where the oxygen's getting in, but these other things have been blocked to some degree. What does that result in? An excessive amount of this. And that initiates the cancer. And you will see that this is really common. This is not an issue that doesn't touch most everybody. So how common is it? We looked at 50 subjects. We randomly selected them, but they presented the claims. These were not old people. They were not sick. They were not old. They were asymptomatic. They felt pretty good. In fact, they were so health conscious, they deliberately came down to these clinics to have their health tested. It wasn't just in Carson City where I live. It's also in LA, Grand Junction, and we went over to the Orient as well. And we tested them. We tested their mitochondrial function to see how well they were doing with this. How well did they do that? We found out that 27, basically half of them, were normal. 40 years old, healthy, asymptomatic. What do you think the 60-year-old group is going to show me? Half of these guys were abnormal. 36% of them had less than 90% of predicted. 26% of them had less than 80% predicted. And 12% of these healthy 20 to 40-year-old kids were in what I call a serious pre-cancer state. They're bound to get cancer sooner or later. They had less than 60% of predicted. They're healthy, they're asymptomatic. Keep that in mind. So it's very common, really common. In measuring the mitochondrial function or oxygen utilization of thousands of patients of all ages, and this is interesting, not one of them that I've seen who has had optimum mitochondrial function described as 100% of predicted or better, not one has ever been diagnosed with cancer. I've not seen one of my patients who has a mitochondrial function over 100% ever come down with cancer. It hasn't happened. I've been doing this for 12 years now. Conversely, I see a lot of patients with cancer. Some of them are advanced, some of them are, basically stage 1 lumps, not advanced at all. And when I measure their mitochondrial function in all those patients, it's been over 80 cancers of all kinds, not one of them has had optimal mitochondrial function. So the question is, why? What's all this mean? Well, to understand this better, this paper is kind of seminal, and you can get this paper. It's on a PDF. You can get it for free on the internet. Gatton Gillies, why do cancer cells have high aerobic glycolysis? In other words, I implied to you already that cancer starts when the environment is hypoxic. And so cells that are in that environment are going to adapt to that hypoxic situation. And the cells that adapt the best, those are the ones that turn into cancer. But later on, that situation can be entirely different. Later on, that environment usually is aerobic. So later on, when you see the cancers actually developing, they'll be developing and growing in an aerobic environment. You can put them in hyperbaric oxygen and they'll be just fine. They're not affected by that, and that's what this paper is talking about. Why do cancer cells, how can they live in a high aerobic environment if what we just said is true? And that's what the paper set out to answer. And the conclusion is because it's the survival of the most adaptable. Precancer or latent cancer cells have a survival advantage in hypoxic environments. So you make the environment hypoxic. There's certain cells in there that are going to have an advantage over the other cells. They're going to feel better at this. They're going to do better in this environment. Okay? Hypoxia is the trigger. So remember that. Hypoxia is the trigger. It selects out those cells who already have... yeah, okay. It selects out those cells that already have a functional hypoxia. So just imagine, say, 100 cells in an area of the body. We make that body hypoxic. Out of those 100 cells, let's say 8 of them already have this functional hypoxia we talked about. That area becomes hypoxic. Those guys say, yeah, this is for us. We can do this now. We've got a big competitive advantage on all the rest of the cells. Let's just turn cancerous and learn to live in this situation. And that's exactly what Gillies and Gatton proposed. It selects out those cells who already have a functional hypoxia. These are the cells that can adapt best and actually have a proliferative advantage. And then they go on to describe how that hypoxia develops. And they have very strong data to show you that it starts with hypoxia. All cancers start from a hypoxic environment. Now, that environment could be localized. We know this. So you can have a localized area in your body, like a tooth. You could have a localized area in your lung that's hypoxic. You could have a localized area that's been traumatized, certainly, that is hypoxic and never quite comes out of this. And those are the areas that are going to turn cancerous. So here's basically the bullets that come out of their paper. Carcinogenesis begins in a hypoxic environment. This forces cells to adapt and rely on glycolysis. That's energy production without oxygen, and favors cellular phenotypes that do well in a decreased oxygen environment. In other words, cells that already are used to functional hypoxia. This downregulates mitochondrial function and hence apoptosis. So these cells adapt by downregulating their mitochondrial function, and that means they get to not die. They get to just live longer. It also creates a heavily acidic microenvironment. So as they're downregulating their mitochondria, they're depending more on anaerobic glycolysis. They're producing a lot more lactic acid. This is creating a heavily acidic environment in that area, which gives it a competitive advantage with the other cells. The other cells cannot survive in that. So gradually, the cells that don't have this functional hypoxia are slowly eliminated, and the cancer's taking over at this point. It also favors cells with a P53 mutation. So P53 mutation cells can survive in a heavily acidic environment, whereas cells without that mutation can't. And that's a mutation characteristic of almost all cancers. And also, that acidic facilitates breaking down of the extracellular matrix so that that cancer can spread. It's growing faster, and now it can spread more easily, and even metastases. Now, eventually, the tumors become vascularized, okay? But by this time, they're already adapted to this whole thing, and the whole thing's going on. And this is called the Warburg effect, the fact that the tumors live in a highly vascular environment, and they choose not to use oxygen. Isn't that crazy? They're sitting in the middle of a pool of oxygen, and it's to their advantage not to use it. Okay, so optimizing mitochondrial function. So what we want to do to prevent cancer is to be in the 50% of the kids that had optimal mitochondrial function. That's what we want to do. Incidentally, that's what you want to do to prevent every disease there is. As Dr. Haley pointed out this morning, there isn't a disease there is. There isn't a chronic degenerative disease that isn't associated with decreased mitochondrial function. It doesn't happen. So you want to be in the group with a good mitochondrial function. Now, how do you do that? And if you have cancer, don't you want to treat the patient in some kind of way to start up-regulating the mitochondrial function? You could slow down that cancer, possibly even reverse it. I'm going to show you some real interesting data before this presentation is over that touches on that. So you want to optimize mitochondrial function. How do you do it? You optimize the ratio. Remember that ratio. That ratio should be highly in favor of NAD. If it starts getting in favor of NADH, the whole thing shuts down. Okay? So what do you suppose the ratio is now? Like 1 to 10, 10 to 1, 50 to 1, 100 to 1. The optimum NAD-NADH ratio, 700 to 1. 700 to 1. That means 700 more of these guys than that. Where do you think that's going to drive that reaction? Do you think that everything possible involved in that cell is to drive that reaction in this direction, right? Because it knows that's where its health is. That's where its survival advantage is. So we dramatically want to improve the NAD to NADH ratio. If that ratio starts to decrease, mitochondrial function slows down, and this whole set of adaptation phenomenon that ultimately creates cancer begins to set in. The optimal ratio, 700 to 1. It's huge. Now, let's talk a little bit more about NAD, and then I'm going to come back to that ratio and what you can do about it. But NAD, I painted this picture like this is what it does. There's a lot of other things it does, too, that you should know about. And so this is a paper that came out in 2003 that is a review paper on NAD reaction. It says NAD is emergence of putative metabolic regulator of just about everything that's important. Transcription, longevity, several age-associated diseases, including diabetes, cancer, neurodegenerative diseases, and I will maintain to you every disease there is. That's NAD. You want that ratio to be good. Calorie restriction. We all know that it's indisputable, at least with animal studies, that calorie restriction will very significantly extend longevity. Has been shown to decrease the incidence or delay the onset of some of these diseases, okay? Studies in yeast suggest that calorie restriction functions by increasing the NAD level, or this ratio. And since this came out, there's even more studies that show this. Calorie restriction works by increasing the NAD to NADH ratio. If you overeat, you decrease that ratio. If you undereat, you increase that ratio. Why is cancer rampant in civilized societies? Might have something to do with the overeating thing. NAD is rate limiting for ADP, adenosine diphosphate. These reactions are involved in a few things that are important, like cell signaling, the control of processes in the cell's nucleus, including this little thing here, which is sort of important, DNA repair. We've talked about apoptosis. Oh yes, and telomere maintenance is controlled and rate limited by NAD. Another function of NAD in cell signaling is as a precursor for the cyclic ADP ribose. What does that do? That regulates all the intracellular calcium channels. And that's another thing if you look at degenerative disease, all degenerative diseases associated with abnormal calcium channel activity. You've heard of sirtuins. They have sirtuins. SIR stands for the silent information regulator genes. So sirtuins are sirtu homologs. They act that way. Sirtuins act by removing acetyl groups from proteins in the presence of NAD. All sirtuins are NAD dependent. Sirtuins are hypothesized to play a key role in the organism's response to stresses, such as heat or starvation, responsible for the life-extending effect of calorie restriction. So NAD once again. The sirtuins regulate nuclear transcription, that's protein making, through deacetylation histones and altering the nucleosome structure. These activities of sirtuins are particularly interesting because of their importance in the regulation of the aging process itself. Cancer dramatically goes up the older people get. So do chronic degenerative diseases. This is the connection. Sirtuins are NAD dependent. So while NAD does all these important mitochondrial functions I'm going to focus on from here on out, I wanted you to know there's a whole lot more that's going on with that ratio than just cancer. Okay, so this is a really fascinating study. It came out in 2009. And what's called pharmacological stimulation of the NAD oxidation. In other words, pharmacological improvement of that NAD to NADH ratio. And so they found a drug's called beta-lactone, and it oxidizes NADH back into NAD and improves the ratio. And they start off by saying that this ratio plays a crucial role in cellular energy metabolism, and dysregulated ratio is implicated in metabolic syndrome. So here they're looking specifically at diabetes, and I'm here to tell you absolutely this is what causes diabetes. If you don't want to get diabetes, have good mitochondrial function, you will never get it. So they used beta-apicone, and they had some diet-induced obesity mice. And they noted that as soon as they oxidized the NADH, the NAD improved that ratio. It strongly provoked mitochondrial fatty acid oxidation in vivo and in vitro, and dramatically ameliorated their key symptoms such as getting fatter, having intolerance to glucose, getting high blood fats and fatty liver. This is kind of like going on all the time. This published a study not too long ago, and they now show that they have to reject something like 30% of the potential liver transplant candidates because they all have fatty liver now. This is epidemic. The treated mice also showed higher expressions of the gene related to mitochondrial metabolism and caloric restriction, consistent with increased mitochondrial biogenesis. And so what does this mean? They say as they improve the NAD to NADH ratio in these otherwise sick mice, they got more mitochondria. And the mitochondria worked better. That sounds like a pretty good solution for our problem here. And their conclusions were pharmacological activation of NADH oxidation by lapicone resolves obesity and related phenotypes in mice, opening the possibility that it might provide the basis for a new therapy in the treatment of metabolic syndrome, if only they could find a drug to do this. Ozone therapy. How many people in here use ozone, by the way? Just curious. Great. Good. Ozone therapy corrects the ratio. It doesn't matter if you're putting ozone in a tooth or if you're putting it back into a ganglion or where you're putting the ozone. It corrects this ratio by oxidizing NADH to NAD. So you get your ozonite. Ozone reacts instantaneously, no matter where you put it. If you inject it in the tooth, if you put it in an enema, if you put it in the blood, within nanoseconds, it's gone, no longer is there anymore. And instead, what you have is these peroxides that we call ozonides. They, in turn, oxidize NADH to water, NAD, and O2. They supply O2 to the cell and NAD. You think that might jumpstart mitochondrial function? In the same way the beta-lactone does? The idea. Oxidation therapies are enhanced with the addition of oral NADH. So I find that it's a pretty good idea, at least for the first week, at least 4, 5, 6 weeks, to throw a little NADH into that system as you're hitting with the ozone. Ozone forms peroxides. It does not form free radicals, only in really high pHs. So we're just talking about peroxides. They react ionically with double bonds to produce the peroxides, called ozonides. Most ozonides form from the short-chain lipids, which means they can penetrate lipid cell membranes like mitochondrial membranes. They can penetrate them because they're short chain. Ozonides are stable for days to weeks. So you might give one ozone treatment, but that's going on for days to weeks after you do that. And they're selectively reactive. Once in these cells, they oxidize NADH to NAD. The enzyme induction effect can last for days to months. And this is the way you can do it. There's all kinds of ways to do it. You can mix it in blood and infuse the blood bath. You can give it as an enema. You can ozonate saline and give that as a drip or infuse it into an oral cavity or some operative cavity. You can give a soft tissue injection, a periapical injection, or an injection. If someplace hurts, you know what's a good idea to do? Inject ozone where it hurts. The odds are pretty good that the reason it hurts is because of that NADH ratio is off, and you're getting lactic acid. Abscess insufflation, you can take a stapedent, suck out the pus, shoot in some ozone gas or some ozonated oil or some ozonated saline or whatever, and cure the abscess without having to put the patient through a lot of trauma. The transdermal ozone saunas work very effectively. So these are a lot of the ways that this very interesting therapy can be used in almost every part of the body. So how much time do I have left? How am I doing? I got 20? Great. All right. Okay, so now we're going to finish up here with some a little practical stuff. This is a paper that comes from Velio Bacci. Velio is, I've written a couple papers with him. Everybody knows him. Everybody knows in the world knows Velio Bacci. He's been around forever. The name of the paper is Restoration of Normoxia by Ozone Therapy May Control Neoplastic Growth. A review and a working hypothesis. So this is a good paper to get if you want to learn more about this. And because he reviews the reasons why ozone therapy ought to do what I've just proposed it would do. He says in contrast to normal tissues, tumors thrive in hypoxic environments. They also thrive in aerobic environments. And then come down here. During the past 2 decades, it has been shown in arteriopathic patients, that's atherosclerotic patients, that ozonated autohemotherapy is therapeutically beneficial because it increases oxygen delivery in the hypoxic cells by oxidizing the NAD to NADH and leading to normoxia, or better yet, leading to an improvement in the way the cells use the oxygen they already have. And then this was an interesting paper. The prospective study was designed to assess the effect of ozone therapy on tumor oxygenation. So they took 18 people. Systemic ozone therapy was administered by autohemotransfusion on 3 alternate days over 1 week. So only 3 treatments in 1 week. Tumor oxygenation levels were measured using needle probes before and after the 3rd session. Overall, no statistically significant change was observed in the tumor oxygenation in the 18 patients. However, a significant decrease was observed in hypoxic values. They utilized the oxygen better. They actually started to utilize the oxygen better. Remember, cancer cells have functioning mitochondria. They just turned them off. So by making some changes, it is possible to start turning them on again. So this patient is Swami. Swami was 76. A follower referred him to a colleague of mine, Dr. Robert Rowan. Many of you know Dr. Rowan. At the time, he was in the hospital with stage 4 colon cancer. He was on death's door. He was given 2 weeks to live. This is a dramatic case. I told this Dr. Rowan told the acram that the rules for him to go to Rowan's clinic were no ascites, able to walk in the door on his own power. I was asked what he could do to get enough strength to get to us, and he recommended a few supplements, and a couple weeks later, he went to Dr. Rowan's clinic. This fellow wanted no treatment other than ozone therapy. That was it for him. So here's the, I don't know if the slide's not really showing up real well, but here is the, these are dates. Okay, so these are the left and right liver. This is the left liver dome. This is the right liver dome on this date here, which is in 110. And again over here on 110. and here it is at 410. So you can see that the liver mets went down in size in 3 months. Again, all he received was ozone therapy. Alkaline phosphatase, which is a major indicator of what's going on in cancers, fell rather dramatically as well. In May 2011, Swami's MRI showed that his liver lesion, quote, went away. Swami was feeling great, but he remained anemic, continued to bleed from his primary, still had the primary lesion. So he called, and he got a surgical resection of the primary, and the surgeon agreed to do it. The surgeon's oncologist called me absolutely shocked at what they saw. This is the first time I've received unsolicited calls from orthodox cancer doctors. They did agree to resect the primary. At surgery, there was no evidence of metastases. The surgeon got a clear resection with anastomosis. And you can't see this, but I can tell you the main thing I want to show it is, here's his albumin, which is, I think it was like 2. Yeah, his albumin was 2. And by May, the albumin had popped up to 4. This guy was getting better and better. And they resected the tumor, and then this is the MRI. And I'll just go to the very last line here. It says, interval resection of the known carcinoma. I do not see any evidence of local, regional, and metastatic disease. And this was almost a year after he first walked into Dr. Rowan's office. Ozone treatment alone. Now, I don't, I treat a lot of cancer, and I wouldn't just give the patient ozone because I don't think this is a money bet. But this is a good case example that does point out the possibility that you can have when you use an oxidative therapy like this, and gives us an idea and also how it can work. And also, I hope you understand that if somebody is being treated for cancer, I don't care whether they're getting conventional chemotherapy, they're getting radiation, they're getting chemotherapy like IPT, like I do, or they're getting some other sort of therapy, there's no way you're going to do anything but improve the outcome of that therapy if you don't, at the same time, improve mitochondrial function with ozone therapy. Now, having said that, I will tell you, it's really hard. And it's really hard to improve mitochondrial function just with ozone therapy. If I take 10 people with poor mitochondrial function and I give them all ozone therapy, I might have 1 or 2 show me a real good turnaround. What's up with the other 8? What do you suspect? Mercury, heavy metals, things that we can't get out, things that we can't detox. So I think it's very critical, even though this talk of mine has been on this particular aspect, that we understand the mitochondrial function involves a lot of things. It involves hormones, especially T3. It involves stress. I've seen mitochondrial function be shut down in a matter of 3 weeks from a stressful situation, emotionally stressful situation. It involves fitness. It involves things like sleep and sleep apnea and the quality of your sleep. And there's just a whole potpourri of things that are involved with improving oxygen utilization. But I think ozone can be very effective part of that whole big picture. So I'll leave you with a few resources. I have a few minutes left, so I'll take some questions if there are any. I did write a book. If you want to learn all kinds of good practical stuff, dosages, applications, how it's given, the whole shtick, you can get this book. It's called The Principles and Applications of Ozone Therapy on Amazon. We do offer an ozone certification course. So you can learn about how to do this. A lot of the people here in this room have been to that course. And you just go to www.ozonecourse.com on there. Also listed on there is Dr. Malika and Harris's course, their dental course. So that's sort of a good resource for you to tell other people if they want to learn more about this. They can either get that book and or go to www.ozonecourse.com and get all kinds of information on how to learn more. And I would encourage you to join us and quite a few other dentists that have already joined the American Academy of Ozone Therapy. We'll be in Dallas in April 40th. I'm sorry, that date's wrong. Okay, so it's 13 to 16. We changed it. For this group, I think it was competitive for that date, right? So anyhow, Hopefully we can get you guys down there to join us at that time. We have a great meeting with all kinds of people, anywhere from chiropractors to a lot of vets coming this year, and it's a good meeting time for us. And that's it for me. So, I have a little time left. I could take a few questions if anybody wants.
We should just take like 2 questions and then we'll go to the next speaker.
Okay, 2 questions.
Are you
Okay.
going to be here for the forum?
I will, yes.
Okay.
Yeah. Okay, good. You're doing a good job. All right. Okay, thank you.
Thank you, Dr. Shallenberger.